I'm Shivana. So as Kate, thank you very much to Kate and Nikki for inviting me to speak to you about this quite important condition, which is probably one of the most common medical conditions you probably come across in schools. The teachers working in the Ipswich and Woodbridge area, you probably would have seen my name on lots of letters and things like that. And it's a real pleasure to be working alongside you all. But today I just wanted to talk a little bit more about the assessment process for autism and what was important for you as teachers, the information that we'd need from you and how you could help us. But like I said, I don't know how many people are in the meeting. I can't see you, so Kate will have a look at any questions in the chat and pose them to me, but I'm really keen to keep this as interactive as possible. So, if you've got any burning questions, just do ask, or if there's anything you want to say. So I'll just start off a little bit. So I'm not going to go into the sort of medical nitty-gritty, what is autism, what causes it, genetics, the environment, the heterogeneity, all that sort of thing. But I will share a few links at the end as well that you can look at that might be quite interesting. So when parents come to you and they say they think their child might be autistic, that's what's going through our heads. What do we want to do? But what is important for the parent at that time is what support is there and is going to be available for their child in the long run. And they're concerned, they're worried, particularly around education. That is probably the #1 concern, because like I said, autism isn't so much of a medical issue, it's more of a mental health sort of thing. In terms of how you support children, that's where the real issues will lie, and obviously with education. But then there's lots we can do as clinicians and you as teachers, and it's really important that we work together on this. Now, this is kind of the boring bit that I'll just go through quickly, but it's just to say, really, just for the diagnostic criteria for autism, that's changed over the last few years or so. So if we look at the DSM-5 criteria for autism, it used to be 3 domains. It used to be difficulties with social communication, difficulties with social interaction, and repetitive behaviors and restricted interests, but that's now changed to 2 domains. It's still the same, but what they've done is they've clumped together issues with social communication and social interaction, so that's 1 domain, and the second domain is restricted behaviors and repetitive interests and sensory difficulties. So that's how we categorize it now. I've just highlighted here the important bits, which is symptoms must be apparent from early on. So even though they may present us much older, there must be some functional deficit from very early on. And always the focus in the needs and how to support the needs rather than the diagnosis. And you as schools know that as well, but we know that it's really tricky sometimes because, I know when you're applying for education healthcare plans and things like that, the SEN department, they sometimes get quite focused on a diagnosis rather than the needs. And I mean, that's okay. That's how people understand it. But a lot of children don't actually go away with a diagnosis, but they have got the specific descriptive features for, autistic traits and things like that. But we'll talk about that in a bit as well. And what's really important now, so you would have heard about the concept of high functioning autism or low functioning autism. We don't generally give those as labels anymore. What's really more important is to describe the autism. So autistic spectrum disorder with an intellectual disability, or with a language impairment, or non-verbal autism, or with sensory impairment or things like that. So it's a lot more useful in the diagnostic process to say it like that, similar to how we now describe things like cerebral palsy. And I will talk a little bit at the end about girls, because girls are a specific difficulty in diagnosis of autism because they mask symptoms, but we'll chat about that at the end. Now there is in the DSM-5, they also they describe a new condition. It's not new as such, but they now recognize it as a diagnosis of social communication disorder, and or social pragmatic communication disorder. And what this is really, it's if we go back a bit, it's pretty much the same. It's the first domain, but it leaves out the domain of restricted behaviors and repetitive patterns of behaviors and interest and sensory issues. So we do have quite a few children who come through who don't have these obsessive natures or repetitive behaviors or sensory issues, but they do have deficits in communicating socially. They do have functional impairment in their communication. They struggle with doing reciprocal conversations, to and fro conversations, things like that, taking turns, and they struggle with making inference. You know, we all know people like this. Everybody, all of you, I think, must have at least one child in your class who you think, and so, but the other thing is that these symptoms should not be attributed to another medical or neurological condition. And the importance of that is that there are many medical conditions, many neurological conditions that have autism as part of it, or autistic traits. And these children may be referred to as query autism, but actually that's not the most important thing that's going on here. So they might have something else, like a neurodegenerative disorder or Rett syndrome or something like that. And again, I'll go through that a little bit at the end, but it's just important that we rule out these other specific medical conditions as well. So I just thought we'd have quickly just look, what does autism look like preschool versus school age? Because in the community pediatric department, we have two separate pathways for diagnosing or assessing children with autism who are preschool, so under the age of 4, and the school age children who are over the age of 4. That will include some children who are in nursery. I appreciate that, but for ease, this is how we divide the pathway. And I don't know if we have any nursery teachers or anything like that here, Kate. I guess maybe not, but it's still important to kind of go through it, especially with in the preschool. So in some aspects, the assessment down the preschool pathway is a lot easier than the school age pathway. They're young, they haven't had a lot of exposure to anything else that might, environmentally that might have clouded the picture. I mean, there may be social concerns and things like that we can talk about as well, but for the most part, these what we call Canner's type autisms, they're easy to spot, and you know them, you'll see them. They're non-verbal, or they have repetitive speech or echolalia. They're repetitive, they make noises all the time, they're completely on their own agenda, they won't respond to their name, they won't do what you ask them to do, they don't follow instructions, they don't share enjoyment, they don't follow a point, eye contact is poor, they've got lots of sensory issues, lots of flapping, stimming, very repetitive in behavior, play, stereotypical behaviors. They come up really close to you, they want to stroke your hair, they want to sit on your lap, they want to do all sorts of crazy things. But not all of them do present like that. There are some more higher functioning preschoolers who have language, and it's really tricky to assess these children because as we'll talk about later, the assessment of autism in school age children relies heavily on the speech therapy assessment as well. And these children don't have the maturity of thought or speech to be able to hold a conversation or to look at their understanding of emotions or stuff like that. But for the most part, the children who get referred through for the preschool pathway are very clear cut, very easy to spot, very easy to diagnose, and you as teachers know it before we do. So the school age children, they can present in many different ways, and as you know, the spectrum is really far and wide. The low functioning ones are sometimes easy to spot, but it's difficult to differentiate with things like learning difficulties. But the higher functioning ones can be tricky. But you know them as well, the ones who can't sustain friendships. They play on their own. The girls who want friendships but just awkward about approaching children. The ones who can't hold a conversation and they just talk at you rather than with you. They're very random in conversations. They interrupt all the time. If you if you change the topic, they just go back to where they started from. They have no empathy. They can't understand emotions. Feelings are not important to them. They're rigid. They can't cope with change. They're obsessive. They have lots of sensory issues. You know, the list is very long. So the diagnostic processes, as I said, is different for school age and preschool children. For the preschoolers, it's usually it's the health visitor that picks them up at, say, their two-year check or something like that, or the parents might draw the attention to the health visitor. But a lot of the times it's yourselves in the nurseries who pick these up, and who you know, and we're really, you know, grateful to you for like drawing parents' attention to these things as well. And it might sound like a daunting thing to say to a parent, you know, I think your child has got, you don't have to say they have autism, but I think they have got some difficulties with social skills or interaction or language or things like that. And maybe you should see your health visitor, and then from there they can take it. So usually a health visitor referral, and the health visitors make really good referrals, very long, detailed referrals. They go into the social history and everything else. They're usually quite good. And then the health visitors will do what's called a schedule of growing skills, which is a screening tool for developmental assessment. The GP referrals, they can come from the GPs, but they're not nearly as good as the health visitor referrals, I have to say, because they don't have the time to spend. They don't go visit these children at home. They can't do developmental assessments, and sometimes these children may already be under a speech therapist, and they'll refer, which is really, really useful. A nursery report, I've put here essential, but a lot of these children aren't in nursery. But it is so useful, and if a child is in nursery, we will generally ask for a nursery report from what you think, because that you know, the behaviours by definition have to be pervasive. So what the health visitors referrals are usually what parents report, but the nursery report is what you see, you actually, you know, deal with every day. So it's really, really useful to have that information from yourselves. Depending on the referral, then we have a system which is called a multidisciplinary assessment, which is done in the Ipswich Child Development Centre. So we call it an MDA process, and we generally will try to put the children who are less than 4 through this process, where they come in for, it used to be 3 weeks, so 3 mornings a week for 3 weeks, and then the 4th week was a feedback week. Since COVID, we've had to change lots. We used to have 3 children in at a time, or 3 families in. Then we've moved from the hospital to St Helens House, so we haven't got all the resources that we used to. So at the moment, we're still seeing 1 family at a time, one after the other, but that's going to change very shortly, and we're going to go back to seeing 2 families. And it's very useful to have the children together, because we can see how they interact, how they clash, how they, you know, how they are with strangers in an unfamiliar environment. And so we do, you know, various assessments. A developmental assessment is very useful, and we do tend to do what's called the Bailey 3 developmental assessment tool on most of the children. So we get an idea of whether this is a child with intellectual disability or global developmental delay, as it may be, and that's really useful for schools to know, and for us to know in sort of recommending where these children should go. Now, for the most part, a lot of these autistic children, even what you would call profoundly autistic and non-verbal, they're actually cognitively very able. And when we do a developmental assessment on them, so when we're looking at the non-verbal parts of it, they actually don't do very badly at all. The things they fall down are the language sort of tasks, and the pretend play and imaginative play. But anything like a puzzle or anything like that, they go through like really quickly. So this is why the developmental levels are useful, because if we find a child who is actually really low and you know, performing at the age of less than, say, 18 months or 12 months, then we know that there might be something else there, maybe something we need to look into, like genetics or neurological or something like that. So that's why developmental levels are so useful for us. Of course, if you have a really profoundly autistic child who just cannot work on your agenda, and we do have a lot, but you know, the nice guidance, which I'll talk about in a bit. So it does say that you have to take a lot of care and be cautious when interpreting an autism assessment for a child less than 18 months of age, because of these reasons. But if you can't find another cause for it and you're pretty sure that it's autism, then you can give a diagnosis. However, if you think that it might be something else, then be careful about giving these diagnoses. In the MDA process, we've got a range of professionals. We have a specialist health visitor, a speech therapist, an OT, a paediatrician, psychologist. We no longer have a physio there all the time, but if there's a concern, a physio can attend as well. At the moment, we do face a lot of challenges. The sheer number coming through for under 4s is just increasing, and our waiting list is about a year. So we've been doing a few outside MDAs, which means that we just sort of see a child with say a paediatrician and a speech therapist who knows the child and just finish up things like that. It's not ideal, but if parents are on board and they know this is autism and they, you know, and we know what we need to do in terms of education, then we can do it that way, and we can share reports with yourselves. But we do encourage for the MDAs, for nurseries, to attend feedbacks. And we do make an action plan and management plans and give some strategies, and we more often than not we will recommend education and healthcare plans be initiated. We know the limitations, we know all the issues that you face with, you know, referring for EHCPs, and we're very aware of that. So, you know, the school age pathway is different. It's still a multidisciplinary pathway, but it's not as joined up as the preschool pathway. There have been various times that we've tried to do something more joined up, but it just hasn't worked. The school age pathway is much bigger than the preschool pathway. I mean, I'm a trained community paediatrician, and my training is with neurodevelopment and neurodisability and neuromuscular. But 90%, I would say, of what I do is autism, which is, you know, sometimes not the most rewarding thing, but it is the thing that is most, that you see out there, that people are concerned about, that they want us to look at, that will be useful for education and for other purposes. So we see children between the ages of 4 to 11. Beyond 11, these children will be referred to, so the NSFD service have got something called the ADIS service, which is for adolescents. So referrals usually come through via a GP, or sometimes a school nurse, sometimes a speech therapist. More recently, the referrals aren't coming to us, they go directly through Barnardo's. I don't know if you know that there's Barnardo's, there's a new sort of system for school-age children to be referred for whatever assessment, whether it's for autism or for mental health issues or for ADHD. All the referrals go through there now. Schools, unfortunately, are not able to refer directly, but we will always ask for school information, and if that is not present in the initial referral, we won't accept it. We have some issues, say, with home educated children, and we have to think carefully about how we accept those referrals. Generally, we'll just accept them without a school report, but usually we will ask for a school report, again, because it's a pervasive condition and we want to know what this child is like in school. And, you know, parents will report stuff, but it may not be seen by anyone else. So if school has seen it as well, then that's really useful for us to know. So I've just put a little like learning point there for you guys about what useful information we would like to have, which is, you know, general concerns. Learning levels, really important. You know, not necessarily, we don't necessarily need an EP at that point, but it would be really good to know whether they're average or what they struggle with or things like that, what you've done to support the child, and then the specific things for social communication. So interaction with peers, adults. Do they prefer younger children, or do they prefer to play with children much more mature than them? What are their conversation skills like? What are their play skills like? Do they have pretend play? If someone joins them, are they okay with that? Are they flexible? Really important is social background, if you have any information on that. A family history of autism is always important, and sensory processing issues and that sort of thing. So what happens next? So if we accept the referral, then we send out specific social communication difficulties questionnaires, which I was hoping to put in a link here, but I can't. I think it's on another slide. But most of you would have seen this. So it's the same questionnaire that goes out to parents in school. There's a little difference at the end in terms of the free text. But we send those questionnaires out to you guys and to parents. They come back. We look at this now. We can score it, but the scores aren't really as meaningful as the free text, as you can imagine. And then we take this information back to. We used to have a meeting. We don't anymore. We just analyze all of the information, and then we make a plan. So the plan usually is more often than not, we will put the child for a paediatrician appointment and a speech therapy assessment, which is, again, by NICE guidance. For multi-agency assessment, you need to have more than one professional who is trained in the assessment of autism to give an opinion in two different sort of assessments. So it could be speech therapy, it could be paediatrician, but it could also be psychology or something like that. So some of the children we may just put for a paediatrician appointment if the school information, particularly if the school information is not as suggestive as, say, the parent information. And a lot of the times you all are very correct, and a lot of these children may not have autism. They may have other things that we'll talk about in a bit. Sometimes we might pass directly to psychology, but that's rare, and psychology, well, capacity is a big issue in our department. Oh, this is the questionnaire. I'll share it at the end because I don't want to lose the whole presentation, but I can also, when you look back at this, you can access that as well. But it's just the same. It's just asking about issues with communication, social skills, sensory issues, repetitive interests, eye contact, empathy, emotions, tone of voice, that sort of thing. So if I just move on to what the actual assessment is like. So usually a highly specialist speech therapist will see the children at school, and they will generally have a discussion with a parent and a teacher. They'll observe them informally at break time or in lesson, and then they'll do a formal assessment of their social use of communication. So they're looking at reciprocal conversation, understanding of social cues. They look at pictures, ask the child to predict what might come next in a social situation. They may do games with them. They look at turn taking. They look at eye contact. They look at lots of different things, which is really quite useful. Waiting times for speech therapy isn't so bad at the moment. Waiting times for a community paediatrician, unfortunately, is very long. So it's about a year, at least for my list. I think it is the same across the board. So they will usually have a speech therapy assessment prior to the pediatric appointment. And sometimes one appointment is enough. It's an intense appointment, as you can imagine. But with all the information that we've seen from yourselves, from the referrer, from the speech therapy assessment, and from our observations, and sometimes we might do a bit of a formal sort of ADOS type assessment, just use tools from the ADOS box, which I'll talk about in a minute. And sometimes it's really clear and we can give a diagnosis at that first appointment, but sometimes we need to have another appointment to clarify, and that's when sometimes we may proceed to doing an ADOS 2 assessment, which a lot of you may have heard of, which is it's a play-based assessment. It is the gold standard for autism assessment. So it's sort of like different modules for different age groups or verbal abilities. So there's one for children who are non-verbal, one for like sort of 3 to 5 year olds who are a bit verbal, but maybe just phrase speech, but can't really hold a whole conversation. And then the module 3 is for the older children. And then we can use a module 4 for adolescents and adults. So it's a gold standard of autism assessment, but it is not diagnostic, even though the word diagnostic is in ADOS, which is Autistic Diagnostic Observation Schedule. But it's important to know that it is not diagnostic. and it has to be considered in light of everything else that we have, all the other information we have. What's really important is we have to, you may have a 7 or 8-year-old, but at the learning level of a 4-year-old, you have to target it to the child's learning needs. Otherwise, your scores will not be correct. And so, as I said, lots of things can impact on the scoring. So learning difficulties, speech delay, attachment anxiety, behavior, all sorts of things. Often we might do a school observation, but if things are still not clear, we may ask our psychology colleagues to take a look, and they have got a pathway called the Enhanced Autism Diagnostic Pathway, where they will do a bit more enhanced work, and they'll see the child a bit more often and the parents, and do further sort of psychological therapy work with them, and then come up with an answer. But lots of times we don't really know what is going on. Really, there are so many things that impact on the diagnosis and the assessment of autism in a school-age child. So, differential diagnoses or comorbidities. Learning issues are the most important one, I think. If a child's got a learning disability, then they will not be able to interact very well with peers on a age-related basis. Peers will find them a little bit maybe not at their level, so they won't want to really be friends with them. Speech delays, the same thing. So the children who have a speech delay, who try to communicate with their peers who can't understand them, or maybe they use Makaton or something like that and they can't understand that, it does get quite frustrating and soul destroying for a child sometimes. And so they will learn to play with younger children, or they will want to be on their own. So it does cloud issues a lot. So sometimes we will ask schools when we write back to say, can we get an education psychology assessment or something like that? And we're not trying to be awkward. It's just, it's really useful in the assessment sometimes. There are lots of other medical issues and non-medical issues that we have to think about. So there are, as I spoke about earlier, so other genetic issues that can present as autism. So Fragile X is the most common cause of genetic cause of learning disabilities after Down syndrome. And children with Fragile X commonly present with autistic presentations, but it's not always the same sort of autistic features you will see with sort of Kanner's autism. But it's something that we have to think about. And often we will ask for, if a child has got a learning disability and autism, we will investigate them, and we will ask for something called a microarray, which looks at their chromosomes and the different parts of the chromosomes. But also we will often look at Fragile X. The amount of positive results we get is very, very, very low, but we do get them, and you don't want to miss them if you get them. Rett syndrome, actually, prior to the DSM-5 criteria for assessment of diagnosis of autism, Rett's was included in the diagnostic sort of criteria pathway. It's been taken out now, but Rett's is another genetic condition where you have neuroregression. And these children, I have had a child who was referred as autism, but it was very clear that actually she was regressing very rapidly, and she had Rett's. So that's, they lose their speech, they lose their hand function, their hands are always in the midline, they have really difficult to control epilepsy, things like that. So other things that have to be considered, so, fetal alcohol spectrum disorder, but that might not be automatically clear that that's an issue, and parents have to give that history. We always ask the history of alcohol in pregnancy, and children with FASD do present, they differently. A lot of them do present quite differently, and sometimes they might be, some of them may get a diagnosis of autism. Attachment, of course, is big comparative condition with autism, and I've had children referred for autism when they were quite little, and then there was lots of neglect and trauma, and they were just presenting as scared and withdrawn and things like that, and then actually you see them after they've been taken into care, and they're different children altogether. So we have to keep these things into consideration and don't rush to give diagnoses of autism for if you're not sure, because autism is a diagnosis for life. Anxiety, I'll talk about that in a bit, but especially in girls, actually autism presents a lot in girls with anxiety. ADHD is an interesting one. So it can be very comorbid, but we do get referrals. I say, please assess for autism or ADHD, which isn't really helpful because we do autism and it's a separate agency to diagnose, assesses ADHD, which is the NSFT. But we have found that, you know, we've seen children and they clearly had ADHD and they are treated, and then their autism is very apparent. So it's, you know, we have to think about that. I spoke about safeguarding, exposure to neglect, abuse, understimulation, and that we see that a lot with the preschoolers, the understimulation. They come in and they're like, they've never been exposed to toys or anything like that, so they don't really know how to interact or play or do anything. Behavioral difficulties is a big one. So a lot of these autistic children will have behavioral difficulties anyway, but sometimes it's not autism. And you know, this is the trouble with school-age children. They have had lots of other things that have happened in their lives that will impact on their presentation. Epilepsy, I'll talk about that in a minute. But of course, you know, things like if a child presents with something that might be an unusual kind of tonic-clonic sort of fit or something like that. Someone might think it's a mannerism or vice versa. Usually it's vice versa. OCD is an interesting one. So obsessive compulsive disorder. So lots of people with autism may be thought of as having OCD. There's an interesting way to sort of differentiate the obsessive qualities of OCD versus ASD. So children who are obsessive, who have autism, they're obsessive over things because they like them, because it gives them pleasure. They like learning about planets, or they like learning about water bots or whatever. OCD is it's compulsive, so they're obsessive about things because if they don't think about it or do it, then something bad will happen. So that's just like a kind of a basic way. Obviously, it's more complicated than that, but it's a basic way of sort of having an idea about the difference between ASD and OCD and knowing that the two do coexist quite a lot. Tics and Tourette's, a lot of children with autism will have tics and Tourette's as well, but they can occur on their own. However, for the most part, there will be some other neurodevelopmental issues going on. Self-stimulation, you know what I'm talking about here. So this is masturbation pretty much. So preschoolers, we get referrals for preschoolers who, you know, who they say are having repetitive, you know, whatever behaviors. And then when you actually go into it, they're just sort of like humping the floor or something because it feels nice. And then the last two here are important ones to remember. So we do get a lot of referrals that aren't exactly, it's not quite what you think it is. So lots of reported stuff, but when you really dig down, you know, we have had to make referrals for fabricating illness, which is called something different now, and don't ask me, I can never remember. And some people who just, you know, not very ethical and just want to claim benefits and things like that. So we do have it. But it's just to say that diagnosis is very rarely clear-cut, and you know, they do coexist as well. So just a quick little look at comorbidities with autism. So anxiety is the highest comorbidity, really, with almost 1/3. ADHD is quite high as well, and ODD as well. Again, things like Tourette's, panic disorders, generalized anxiety disorder. So enuresis and incorporesis is they're interesting one. So incontinence, basically, and we do get that a lot with children who are preschoolers, who parents are trying to potty train them and they're really resistant to it. They do not want to. Why should they? All their life they've been doing their poos and their wheeze and the nappy. Why all of a sudden you want me to do a poo in a toilet? You know, that's really a big change of routine for them. And so that's one of the alarm bells that rings when you have a really bright child who's verbal, who's like hitting 3.5 to 4, nearly going into school, but still in nappies. And then if you dig deeper, you will find some other sort of specific pointers towards things like autism and, of course, OCD. They've found things like mood disorders not as high in, say, younger children, but as you get older, they coexist quite a lot. So I thought I'd put a little slide here on ASD and girls, because that's a question that we get. We get referrals, and we get letters from schools that say, this child is absolutely fine in school. The parents are saying otherwise, but we know that there is a that girls present differently and they can mask and so on. And that's a tricky one, because how do you assess a child who is masking? I mean, we have ways of drawing out sort of unusual behaviors and things like that, but these girls are usually really quite clever. But there's a few little things to just to help with the differentiation. So girls present differently. There are less girls than boys, with regards to the incidence of autism. There will be lower proportion of girls, but is it really lower? Because it could be that we're just not recognizing it as much. But girls have fewer and qualitatively different repetitive behaviors. They have their interests, their obsessive interests aren't so out of the ordinary for a girl. So whereas I remember a boy once who his obsession was water butts, and then his brother had an obsession with hoovers. But girls, their obsession might be makeup or ponies or, you know, unicorns or something like that, which is socially acceptable for girls. I mean, it depends on their age and whatnot, but, you know, it's tricky. They sometimes, like I said, they tend to have less obvious difficulties with socializing and behavior in school, but not at home. That's when things there's a safe space where they just explode, where they cry, where they, you know, they can't explain how they feel. They internalize things a lot more. Their social difficulties are more subtle. They are more socially motivated. They want to have friendships. They are aware that they are awkward. They're aware that they're outside of a group and they want to be part of a group. So they try as hard as they possibly can. And they're more skilled in one-to-one interaction than boys. So they, you know, these are the girls who might have one good friend, but not really part of a group or on the outside of a group. And they're the ones who are misunderstood at initial presentation, and they're the ones who present older with anxiety and self-harm and things like that. So these girls, what do we look for really? So does she lack the ability to interact fully in groups, or does she just rely on one friendship? Are the emotional crises often provoked by breaking down of these friendships, particularly when they're teenagers? And are the repetitive behaviors and sensory interests, are they masked because they're normal or social in nature? I put a little note there on children with high functioning autism, and I can't remember why, but if you have any questions about that directly, just ask me. So I thought it'd be interesting to just talk about red flags here. So autism in itself it's a medical condition, but it can be quite vague at times. There's no diagnostic test that you can do, like a blood test or anything like that. You can't do an MRI, but you have to think about these red flags, which could point you into the direction of other really serious clinical conditions. Developmental regression is a big one. They as preschoolers, they will always say that something like the children had some speech and then they lost it, something like that. That's common. But what will put us on alert are children who were, you know, able to have a conversation and not having a conversation anymore. Children who were walking, who are now not really interested in walking. Children who are continent, who are no longer continent. That makes you think about other medical neurological conditions that can be quite severe, that autism can be part of, but not the most important part of. Seizures itself are really important things to look at. So they say 30% of children with autism have seizures. I would say that in my 12-year practice of thousands of children, I maybe have 2. who have got autism, who are autistic but also have epilepsy. However, children who have neurological conditions or who have established epilepsy or who are ex-prem or you know, who have brain things, you know, post tumors or whatever, they have quite a higher incidence of epilepsy. It is nearly a third of them who, autism, who nearly a third of them will present with autistic features, and it can be directly related to their condition as well. Some children will have subclinical epilepsy, but that's very rare. And sometimes it is quite difficult to differentiate between seizures and autistic mannerisms, you know, the flicking of the fingers or the flicking of looking at lights or things like that, the repetitive behaviors. So you'll be glad to know I'm nearly finished. I mean, we really, really appreciate all the help that schools give us, and we really value the learning together, the working together that you do with us. With regards to support, and you know, from the NHS, the support is quite limited. Actually, we are a more diagnostic service. We have got a psychology department that is able to support with things, but capacity issues are massive at the moment. So support has to come from the wider environment, the family, so schools, community. The preschoolers can access the they can all access a post-diagnostic workshop run by a clinical psychologist, and that's for parents. Under fives, the parents can do, like, it's a long sort of 12-week course called Early Bird, which is specific for their child. For the older children, the Suffolk County Council run an Early Bird Plus course, but I don't know much about it because we don't get involved so much. I don't know what the take-up is. For sensory issues, all we have available on the NHS is we've got a sensory online training, which parents can be referred for. They can access specific OT input, and we have got also access to the Children with Learning Disability team, but also really huge capacity issues at the moment. And then there are a few websites like National Autistic Society, West Midlands Autism, which I've got at the end for you. Send yes. We signpost them to things like Activities Unlimited, and these parents can claim for disability living allowance. I think a big part of what we do is what happens when parents do not accept a diagnosis, and when parents do not accept that there is no diagnosis of autism. So we have, like, lots of people, parents who've moved, say, from Europe or African countries and things like that, but that autism is not a big thing in their country, and it can be tricky. Also, so like places like Iraq and stuff like that. It has, well, you know, there are some really, really good parents who will work with us, but lots of them, they don't understand autism, and it's very difficult to get them to come to grips with the diagnosis. There's not a lot we can do with parents who don't accept a diagnosis. It's not like diabetes or epilepsy or something like that, where, you know, if you don't accept the diagnosis, you're going to die or something like that. And some of these children just, they have, but you know, schools know, and we know, and a lot of the times the parents will not allow us to write to schools to let you know. And it's tricky. It's very tricky. If we don't have consent to talk to you, then we basically can't. But again, it's just needs led, isn't it? So we have to manage these children's needs as they come up. Even harder is when parents insist that there is a diagnosis when they are clearly not autistic, and that's a tricky one. And you know, we have not come up with an ideal way of dealing with these parents. And you know, usually what we have to do is direct them to the complaints department. So this is my last slide, really. It's just a few websites that you might find quite interesting. But for the most part, I think, you know, autism, we're always happy to chat with you. There's always someone on call for the week at St Helens House. So if you've got a question about a child, you think that you know, you don't have to call the names. If you feel that you'd like to discuss a particular child with one of us, then, you know, use us. Just ring St Helens reception. I can give you the phone number and ask for the duty doctor, and someone can give you a call, or a secretary can give you a call or something. And that's pretty much my presentation for today. I hope that was not too boring. but I would be more than happy to answer any questions that you might have. I think I've taken off the sharing now.
Far from boring. Thank you, Shivana. Just trying to put my camera back on. Yeah, that was fascinating. Thank you. I'm sure that many of our colleagues that are taking part this afternoon have recognised in some of the children they've taught currently and historically some of the red flags that you've been talking about. So thank you. So there's just one comment in the chat bar, and that was from Ranley, just to say that they appreciated the information on the preschool, because they still have children from 3 years. They have an early years unit. So thank you for that. I'm going to ask if anyone wants to open their microphones and ask any questions to you. So now is the time to do it. Please do either pop your question in the chat, or if you'd like to ask a question directly, please do.
Julie Cox.
Hi there. I was wondering if you can help me. I'm working with somebody who is 14, a girl, and what I've noticed is her mother has reported that for many years this girl stims repetitively by spinning around, singing with headphones on. Does this a lot in their room when they come home from school, when they've been out socialising, interacting with people. Is that a significant indicator necessarily of pointing towards that? There are other sensory issues, but the main one this young person has is with noise. Okay, so stimming by itself is not an indicator of autism, and it's not one of the diagnostic criteria, but it's unusual to see it in, say, someone that age, 14, so they generally grow out of it by then. If you dig deep down, really, if you know, as you said, there might be there are some sensory issues, noise and things like that as well. But if we dig deep down with some social interactions and things like that, we might find subtle indicators of autism. I think what would be interesting is what school are you at? Sorry. I'm working with the Radwell Trust, so I'm in and out of several schools. So okay, this person is now starting year 10.
Right. Okay, yeah. I think that, yeah, it is quite a tricky one once they get to that age. I mean, if the mum is really concerned about autism, and I don't know if she is, but they can access, so the ADIS team, which is ADYSS, they can be referred for assessment through them, but stimming on its own in a 14-year-old, I would say is slightly unusual, but in itself not an indicator of autism. There would have to be other signs of difficulties with conversation, turn taking, social interaction, things like that.
Thank you.
Thank you.
Shivana, there's a question in the chat. Are you able to see that? Would you like me to read it?
Yeah, here we go. So we find the questionnaire quite complex and have sometimes wondered if we as professionals find it hard. Do parents fully understand, especially if they have English as a second language? Yeah, 100%. So the questionnaires are quite a standardized questionnaires that it's not just used by us, it's used across the board. I think other counties use it as well. You know, we don't need, you don't have to like be too specific about the answers. The questionnaires, is everybody familiar with the questionnaires? I'll try to share it if that's okay. Oh, I cannot, sorry, because it's not oh, I need to share the screen first. I'll tell you what, I'll just send it. I'll send it to Kate and she can send it out to you guys online. But it is quite a long questionnaire. There's something like maybe, let me see, 27 questions. And there are things like, there are some strange questions like, have they got an unusual posture? So you might not have even noticed that. But if you haven't noticed it, you just click no. and you don't have to give any extra information. So don't get too bogged down by the questionnaires. You know, what we like is the free text more than anything else. Now, with regards to the parents who have difficulties filling them out, or if they have English as a second language, we sometimes ask, or sometimes schools may help the parents to fill them out themselves. So that's how we get around that. But for the most part, you know, it's just there as a screen. It's not there. We're not going to penalize anybody for not filling it out properly. So please don't worry about it. Okay.
Are there any other questions for Dr. Das? Okay, well, it looks like there are no further questions. So can I just thank you very much, Dr. Das, for your time. We will send a recording out of tonight's presentation, along with the link for the questionnaire, so that I think it's useful for people to hold a copy.
I'll send that to you. Yeah.
If you do find that you do have any questions after today, or those of you that are listening on record, then please do either drop us a line at Medical Needs in Schools, and we can always pass them on to Dr. Das. I don't know if you've included your email address and anything, or if you'd be happy to receive anything, or if you'd rather that we had it through me.
Well, you've got my email address, Kate, so you can say. One thing I will say is the questionnaires, so please don't use them as screens for sending them as a referral. So they're for us to use as part of our pathway, and they are copyrighted and so on and so forth. So but you know, it's interesting for you to see what sorts of questions we do sort of ask.
Well, thank you very much, Shivana, for your time this afternoon, and thank you everyone for joining. Just a quick mention that next week we have another Medical Needs in Schools workshop. It's just been confirmed today, and that was going to be on asthma and exercise, what schools need to know. This is going to be led by Dr. Sarah Nevercote, and will be at a slightly later time next Tuesday at 4:30. It's a workshop that we've been trying to put on for quite a while, and the Asthma Network are going to be involved with that too. So just look out for that email, and we hope to see you next Tuesday. And Shivana, if you'd like to join that one as well, you're very welcome. All right. Lovely to see you. Take care, everyone. Bye-bye.
Thank you.